Tisztelt elnöknő, kedves kollégák, kedves hallgatóság!
Dear President, dear colleagues, dear audience, I'd like to speak about a specific case, and I'd like to excuse myself already because two authors are mentioned here, but it was the Danish colleagues who carried out the actual examinations, and I was not able to mention their names because I don't know their names. I only received the findings, the medical findings. I'd like to present a neuro rehabilitation case from Sopron through this case. So, it was the fourth pregnancy of the mother. A little girl was born, and it was clear that her lower limbs are not moving. At 4 months of age, EMG and ENG was carried out, which supported polyneuropathy, especially in the lower limbs. As for the upper limbs, the conduction velocity showed amplitude reduction, but the conduction velocity was not affected. At 5 months of age, she had a hip operation, and we examined her at 18 months of age. We found a hypathone paraplegia with a reflection. As for the clinical presentation, it showed a polyneuropathy. Genetic examination tests were carried out quite soon, and we treated her 10 times in the form of 1-week treatments with RTMS stimulation of the motor cortex and the lumbar nerve roots. The motor response could not be induced. And we examined the CMT with the heterozygote mutation of the AARS1 gene. We were looking for the motor connection because we are talking about the motor polyneuropathy. We carried out the full exon sequencing on the parents and on the child, and we found a heterozygote variant in the AARS1 gene, which led to an amino acid swap in the glutamine and lysine amino acids, which led to the polyneuropathy. This is a missense mutation. This amino acid swap hasn't been described yet, and Professor Kalman made a search in various lists that we had at our disposal, and this variant of the missense mutation hasn't been described yet, but very probably this is responsible for the clinical presentation, because we have had a very high auto-classification score. And now, what did we do? We have a paraplegia with infant onset at infancy. The child was a bit older, is a bit older here. The transcranial magnetic stimulation is a Tesla size variable magnetic space. It is created, it is focused under this disc. It penetrates the brain and stimulates the motor tract. I stimulate the right motor cortex, and if my left hand moves, the nerve tract is healthy. In this case, we stimulated the nerves responsible for movement in the lower limbs. And you can see the stimulation of the lumbar nerve roots. And you can see that the lower limbs move, which is a good sign that the nerve can be stimulated from the spine to the periphery. And this is where we first met this little girl who is here among us, moving around in the audience. Here she was 18 years old, and she shows us what a hypotone paraplegic patient looks like. She didn't move her lower limbs while crawling when she was supported at the abdomen. And later in April, we could see some movement already. When she was in a harness, she was able to push herself up. It was at her home, and the lower limbs move when she's crawling on all fours. She is able to move them a little bit. Another film at our institute, she is able to move the lower limbs. So you can see the progression of the movement from January to April. We have treated her for during 3 years, and this is in 2023. She's able to crawl on all fours, and she's reversing now. Very cute. But she is able to perform targeted functions. She's able to kick the ball. The movement is better in the left lower limb. We know that CMT affects distal muscles. Look at the left foot. There's movement in the left foot. And we ask her to move her foot, to wave with her foot. Suspended, she's able to walk. She needs some help, but it's not so bad. The lower limbs move, and you can see here that she's walking. It's a flexible suspension on elastic bands, and she's able to stand up from the beanbag. And this is 2025. Time flies. We use computer-assisted programs, and she's able to use them because she has healthy cognitive functions. This is a sensor attached to her leg with a Bluetooth connection with the computer. And when she moves her foot, she's kicking. She sends the elevator to the 3rd floor on the screen, and she needs to hold the elevator for the person to be able to get into the elevator. The sensor is very small. It's difficult to see it, but you can see here that she was holding her foot, and then she retracted her foot. And another one, when she is extinguishing fire in the game. Here's the lower sensor, and you need to extinguish the fire with the water, and you need to keep the water jet on the fires in order to be able to extinguish the fire. So she's able to play these computer-assisted programs. And this is at home. She is working with an assistive device. So what was surprising in this case, in diagnostic terms, and what were the diagnostic and therapeutical challenges? It was a serious neurological symptom at birth, paraplegia. Upper limbs were not affected clinically or neurologically. Professor Kalman is a genetician, and she thought, this alanine transfer RNA synthase mutation was responsible for this polyneuropathy. So it was a missense mutation that hasn't been described yet in the literature. Other missense mutations have been described in 2015 in the Journal of Neurology. 4 cases were described, but not this missense mutation, which is an exchange between glutamate and lysine. During the 3 years when we followed the child, there was a significant motor development, which is unusual in such polyneuropathies. We cannot declare that it's an effect of this treatment in Sopron, because she had therapy twice a week also in Denmark, swimming and another therapy. But you can say that this significant motor development took place during these 3 years when we also provided therapy. And this is the picture of our facility in Sopron. Thank you.